Hello, everyone, and thanks for joining us for this Part B Oncology Rejections and Denials. Today's event is a webinar designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Mulko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators. We call them, or call us, WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Leanne Foster. We begin each of our education's presentations with this disclaimer. It's to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws and regulations and rulings will always prevail. We will provide responses to questions based on the facts given. Just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. So just as advertised, this webinar is designed as an entry-level introduction to Part B Oncology Rejections and Denials. So during this webinar today, I plan to discuss how rejections and denials differ. I'm going to provide examples of common rejections and denials, and I'll explain to you how you can fix or appeal a Part B claim. We'll conclude this presentation then with a question and answer session. To fully understand rejections and denials, it's really important to recognize the path that a claim takes, or as we like to call it, the life of a claim. This is a simplified graphic on how a claim gets into our Medicare claims processing system. That's the multi-carrier system, or MCS, for those of you that submit on a 1500 claim form or the 837P electronic claim. Of course, you'll provide the service. You submit the claim. Most of you submit it now electronically. And the system will either let the claim in the door, as we like to say, or reject that claim. And what you need to do is check reports. Those are the 277 or 999 reports. Most providers, as I mentioned, submit claims electronically, but very few qualify under a waiver under a law that prohibits payment of a service or supplies that a provider did not bill to Medicare electronically. So to confirm claim receipt, providers should use the 999 report. They would use the 277 report for more specific information. Our electronic data interchange, or EDI staff, provides helpful information in the Medicare 276-277 companion guide, and I've included a link to that companion guide here on this slide for you. This companion guide will help clarify and further define the data content requirements for an electronic claim. And it's based on these reports, the 999 and the 277 reports, that you'll know whether a batch is rejected and if you need to correct or resubmit that electronic claim to Medicare. This is a simplified graphic that shows what happens next in the life of a claim. This would be for those claims that Medicare rejects, and we call rejections by the name unprocessable. So if you hear us say unprocessable, it means the same thing as a rejection. Now, one thing you do need to understand, and it's surprising to some people and even some people within WPS GHA, a rejection and a denial is a very, very different thing, and you need to remember that. A rejection is a claim that's unprocessable, and a denial is just that. It is a claim that Medicare has denied. So let's take a look at rejections versus denials. As I mentioned, that some people even within our division sometimes mix those two up, and it's important that you keep them straight because doing so will let you know what you need to do to make a correction. So a rejection is an unprocessable claim, and what happens here is that it's really returned on what we call the front end before adjudication. The reason this happens is because something is missing or incorrect, something's invalid, something just doesn't make sense. And for these claims, rejected claims or unprocessable claims, there are no appeal rights because the claim was really never processed or it wasn't adjudicated. What you need to do for rejected claims is resubmit that service. And on your remittance advice, you will find an MA130 remittance advice remark code. And basically what that states, and the description reads actually, your claim contains incomplete and or invalid information and no appeal rights are afforded because the claim is unprocessable. It also tells you please submit a new claim with the complete or correct information. You will find a group code on those claims of CO16, and that means it's a contractual obligation. I'll be talking about that in just a little bit in a little more detail. A CO16 means you can't bill your patient. The patient is not liable for those charges because you need to correct and resubmit that claim. A denial, on the other hand, is a claim that we have adjudicated. And it's denied because something fails to meet payment criteria. It could be a statutory requirement, and what we mean by that is a requirement based on law. That means statutory. It could be failing to meet payment criteria because it doesn't meet medical necessity. A lot of times, medical necessity denials are tied to some sort of Medicare policy, either a national coverage determination or a local coverage determination. And remember that anything that denies due to frequency is considered a form of a medical necessity denial. Another reason why claims are often denied is due to eligibility. This could be that the provider wasn't eligible on the day that the service was rendered, or maybe the beneficiary wasn't eligible, or maybe the beneficiary was eligible for Medicare but not for Parts A and B under the MAC's administration of claims. Perhaps it was a different payer that should have paid or should pay. So for denied claims, typically there are going to be appeal rights available. And when there are appeal rights available, there is a message on the remittance advice that is MA01. It alerts you to the fact that you do have appeal rights if the certain claim line or the claim itself was denied. Basically, what it states, and in the description it states, if you do not agree with what we approve for these services, you may appeal our decision. And it also goes on to tell you that to make sure that we are fair to you, we require another individual that didn't make the initial claim determination to conduct that appeal. So that provides the appeal rights. It also tells you that when you do submit an appeal, and in order to be eligible for an appeal, you must write to us within 120 days of the date that you received the notice, unless you have a good reason for being late. And while that description actually says you must write to us, there are other ways you can request a denial, and I'll talk more about that in just a little bit. All right, we're moving on now to this graphic, which shows the path for a claim that we've processed. You've provided the service, you've submitted the claim. Either we're going to pay the claim or deny the claim or pay a line or deny a line. And then that remittance advice or that RA is sent out. So let's talk a little bit about the remittance advice. I want to talk about the importance of that, of the information it conveys. Most providers will receive an electronic remittance advice. We call this an ERA, as opposed to a standard paper remittance or the SPR. Depending on how the claim was processed, it may include information about any adjustments made to the claim or denials. It could also include information about something that's missing. Sometimes it provides notice even about refunds or offsets. The ERA provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits or remittance advice. So a lot of information there that will be very, very important in order for you to understand how that claim was processed or why it denied or if it rejected. There are codes that appear on the remittance advice, and they provide information about the claim. Claim adjustment reason codes, we call them CARCs, explain why a claim paid differently than it was billed. And remittance advice remark codes, we call those RARCs, provide more details about an adjustment that's described by a claim adjustment reason code, a CARC. Another type of code, and I mentioned this one a little bit earlier, that appears on the remittance advice, it's a group code. These convey the financial responsibility for the unpaid portion of the claim balance. So a CO, as I mentioned earlier, is a contractual obligation, and that means the provider's liable. So if a claim is rejected, there will be a CO16 group code on the remittance advice. That means the provider is liable. You need to fix it, resubmit it. A PR, on the other hand, means that the patient is financially responsible, stands for patient responsibility. You can find code lists on the Washington Publishing Company's website. I've included the link here on this particular slide. They maintain these codes for CMS. WPS-GHA does not maintain the reason and remark codes, the group codes, or the claim adjustment reason codes. We understand that some of the codes or those descriptions may be rather cryptic, or they may seem out of date. And an example of that is that sometimes when you're reading the description for one of those codes on that remittance advice, it might refer to something that's out of date, such as some of them read or have in them HICN, HICN, which stands for Health Insurance Claim Number. We know that the health insurance claim number has been replaced by the Medicare Beneficiary Identifier, or the MBI, but WPS is unable to change those code descriptors. It is the Washington Publishing Company that does this for CMS. You can find code lists, those reason or remark codes, out on the Washington Publishing Company's website. I've included the link for those also. You will find throughout my entire presentation many of the resources that in that webinar description that you read when you registered said that I will provide for you. So those are embedded throughout the entire presentation. Anytime you see the hyperlinks shown here on slides in the blue colored font. All right, let's talk a little bit about potential actions to choose. And this is what you're going to do after you review that remittance advice. You're going to need to choose your action. So for an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. If the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the claim or the service. You might be able to use the clerical error reopening, or CER, or SIR process to fix clerical errors. CMS defines clerical errors, which includes minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about the SIR process later in the webinar. Another action to consider is an appeal, and the remittance advice notice rather, or the RA, is going to provide those appeal rights to you. Remember, I talked about the MA130 code that will appear on the RA. Another action to consider, of course, is appealing the claim, but you can do that by using our transactional portal. You can use the transactional portal available on our website. You do need to register to use it. You can use that to render a clerical error reopening or request an appeal. And these self-service tools really do offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use these features, and I have included links elsewhere in this presentation. So I do want to talk a little bit more about those self-service tools that will make the potential actions that I talked about quicker and easier for you to accomplish. First, starting with that portal user manual that I mentioned, you can find instructions for using the online transactional portal in the user manual. There's a link to this manual on every single one of our web pages, and it's just under the area where you would enter your user ID and your password to log into the portal. I've included a link on this slide, but if you're looking at the slide or the screenshot I did actually of the tools web page, you'll see the three white boxes up close to the top right corner, but just underneath of the one white box in the upper right corner. That's where you log into the transactional portal. And to the right of that is where you can choose to click on a link to open that portal user manual. Registered users of the portal can also use the portal to check claim status. You can check claim details and view claim actions. And when you're viewing claim details, there is a button labeled More Info that you can click on to view more details about the claim or the claim line. If the claim denied, the details allow you to link to that information. And one example would be if the claim denied due to a policy, there will be a link to the policy when you choose to click on that More Info button. Of course, if the claim is submitted, well, another thing you can view, let me back up here. You can also view if a claim denied due to another claim that's already processed, but you can only do so, you can only find more details, that is, when the claim that already processed is the same provider. We can't provide information about a claim submitted by another provider to you. And this is, of course, due to privacy rules. The portal, the transactional portal, is operational 24 hours a day, 6 days a week, with limited functionality outside of normal business hours. And that is a typo, ladies and gentlemen. That should say 7 days a week. That's why the tongue didn't want to say 6. It is indeed 7, and I'll get that corrected and get a corrected presentation out to you. Missed that in my review and approval of my PowerPoint. All right, the next tool that I want to talk about is the Interactive Voice Response System, or the IVR system. This is a tool you can also use to look at claim status and details. And the IVR is also available 24 hours a day, 7 days a week, with limited functionality outside of normal business hours. Another self-service option is to use the IVR to check claim status and details. Authenticated users can use their voice or the telephone keypad in order to access that claim information. We do have instructions for using the IVR in our IVR operating guide that's available out on our website, and I've included the link for you. There's a resource on our website, very helpful. It is titled Common Claim Denials. I've linked to it here on this particular slide, and it includes the actions to take to avoid some of the most common claim denials, or to, appeal and fix your claim denials. The help in this particular resource is actually sorted based on the reason and remarks codes for various denial categories. I've listed some of them here on this slide for you. You can find uh, help or actions to take as it pertains to denials for bundling or denials for duplicate claims, global surgery rules, payer contractor denials, and provider number denials also. So all kinds of ways to fix those most common claim denials are included in this very helpful resource on our website, and it's listed by category, including those reason and remark codes. Just I bundled these together on one slide. I've talked about the various tools. You can use self-service options available in our portal to do a number of functions or to accomplish a number of functions. You can use that claim search to find claim details. It really is helpful for you to understand why a claim line or a claim denied. There's a lot of information built into that More Info button that will be helpful to you. You can also render a clerical error reopening, but you need to keep in mind that this is only good for some denials and not for others. You can also request an appeal using our transactional portal, and it really is, as I mentioned earlier, the quickest way to accomplish these functions. All right, so let's talk now about whether you need to correct a claim or appeal the MAC's decision to pay or deny a claim. I'm going to talk a little bit more in detail now about the clerical error reopening, or that CER process that I mentioned. This is that process to correct human or mechanical errors. And I said to you earlier that not all denials are able to be fixed using this process. Clerical errors or minor errors are limited to errors in form and content, and omissions do not include failure to bill for certain items or service. So you need to remember that. Some examples of acceptable clerical error submissions are mathematical or computational mistakes, transposed procedure or diagnostic codes, perhaps inaccurate claim entry, misapplication of a fee schedule, or other types of computer errors. There are in that the resource that I have listed here on the last bullet examples of what is okay to be handled as a clerical error reopening and what types of situations cannot be processed as a clerical error reopening. Those are also included in this resource. The link is there for you. Remember, you can use the portal for self-service, or you can also request a clerical error reopening via telephone or fax. This particular article or resource here on your slide tells you how you can do that. If you prefer not to use the self-service option, the transactional portal, you can submit by telephone or fax. And all of that information, the how-tos that is available in that resource. For claim denials, most often you can request an appeal, and remember your remittance advice is going to tell you that. The purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MACs. And MAC, of course, stands for Medicare Administrative Contractor. WPS is a Medicare Administrative Contractor. For the jurisdiction 5 states of Iowa, Kansas, Missouri, and Nebraska, and also for jurisdiction 8 states of Indiana and Michigan. The beneficiary or their representative may request an appeal on any services processed for them, but providers and suppliers may appeal services for which they accepted assignment. So for unassigned claims, providers and suppliers may act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement, such as the CMS Form 1696, which is Appointment of Representative. In addition, providers and suppliers must request or may request rather redetermination on an unassigned claim if Medicare denied the service as not reasonable or necessary, or if the provider or supplier billed in excess of the limiting charge. And the provider or supplier must refund any fees collected from the beneficiary. The first level of appeal is that called the redetermination, and it is the only level of appeal that is rendered by the MAC. So the only level of appeal that we do, that WPSGHA can perform, is level 1. That's called a redetermination. Time frames apply to each level of the 5 levels of appeal when you're submitting an appeal. And additionally, there's a minimum amount in controversy that applies to levels 3 and 5. To meet that level of controversy, or the AIC, you can combine like denials on more than one claim to reach the AIC. It doesn't have to be for the same patient. It can be for more than one patient, but they need to be like denials or denied for the same reason. There are some helpful resources available for you. One is how to appeal a claim determination. That's available on our website. And remember that we do recommend using self-service options for more timely processing. Providers are aware that they have so many days in which to submit their appeal. Some providers are not aware that the Medicare contractors that process the appeals or that perform the appeals also have time frames that they must meet. And I talked to you about that helpful article or resource out on our website called How to Appeal a Claim Determination. I've included the link here on this slide for you, but also one of my absolute favorite appeals process helpful resources, and that is a flow chart. It is one that's updated annually by CMS. I've included the link to it. The last time I checked, when I opened this link and looked at this flow chart on CMS website, it was still for 2023. It had not yet updated to 2024. It may have by now. So just be aware that that does update annually, and make sure that you read the fine print at the bottom left-hand corner of it to make certain you're looking at the correct year. All right. When I described what I was going to cover in this webinar, I talked about the fact that I'm going to talk about rejections and denials and how they differ. I've really covered that. I've talked about how you can fix or appeal a rejected claim or a denied claim. Now I'm going to move into the common reasons why oncology claims are being rejected or denied at WPSGHA. So the final portion then of today's webinar, before that question and answer session, really focuses on data. I used a tool that we call the data dashboard to pull the data that I plan to share with you today. It's an interactive tool that was designed by one of our data analysts in our Insight department. The department where all the data analysts work is called Insight. You might hear somebody at WPS refer to this occasionally. That's the name of the unit at WPSGHA that's responsible for mining data. They're looking at data trends, among other tasks and responsibilities, of course. So let's talk about the data that I'm sharing today. The data that I'm talking about now in the next few moments with you is all Specialty 83 submitted claims for jurisdictions 5 and 8. So that means the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan collectively, all of it. While the dashboard does allow us to drill down by a specific state or states, and even counties. I pull data for our entire jurisdiction, so all 6 states. For those of you that are wondering what Specialty 83 is, it's a code that's assigned to WPS-GHA providers when they enroll. And during enrollment, providers self-designate a specialty. While a provider can designate a secondary specialty, it is only that primary specialty, the one designated during that enrollment process, that is used during the initial claim processing. There are some situations where a provider may request an appeal. They may stipulate or show their secondary specialty in order for Medicare to make payment. But typically, our claims are going to process based on the computer logic, looking at that primary specialty, which in this case is 83, which is hematology and oncology. You can see that in that first bullet here. I requested data for claim submission dates August of 2023 through November 16 of 2023, and that data that I pulled on that day was last refreshed on that day, so actually on November 16. So what this means then, folks, is that any claim submitted for this date range after November 16th is not included in the data that I am going to show you now. Let's start with rejections, those claims that are unprocessable. There are various ways we can review the data or view data in that dashboard. Here are the top rejections for Specialty 83 by reason. So for that 3-month period, Specialty 83 claims, all 6 of our states, 981 rejections occurred because the claim should be sent to HMO. Remember those reason descriptions I talked to you about that are sometimes a little cryptic or may have outdated information. These are actually the reasons from those descriptions that I talked about earlier, those reason and remark codes. So 981 rejections because the claim should be sent to the HMO. So that means nearly 1,000 claims came to WPS-GHA when the claim should have been submitted to the HMO, which is Medicare Advantage or Medicare Part C. In this case, the claim would need to be sent over to the plan, not back to WPS-GHA. Next common rejection is 429. This is because the claim lacks information that's needed for adjudication. Typically, that's going to mean something was missing. You would need to check the claim form instructions, which are included in CMS Internet Only Manual, Publication 100-04. That's the Medicare Claims Processing Manual, Chapter 26. And it is in that chapter that CMS provides instructions for filling out the claim form, item by item by item. So item 1, fill this in. Item 2, fill this in. Well, now you may say, but we submit electronically. There is a crosswalk that says if it goes in item 19 on a paper claim, this is where it goes on the electronic claim, and I'll show you where you can find that in just a few minutes. The next common rejection of the data I pulled, 239 claims rejected because the claim must be submitted to the Railroad Retirement Board. That is another contractor. It is Palmetto that processes claims for Railroad Retirement Board Medicare enrollees. Next, 196 rejections, missing or incomplete or invalid ordering primary identifier. So the provider number, maybe it was transposed. Maybe an incorrect number was used. Those would be the types of things that you would want to look for here to avoid this rejection. And similarly, at 135 rejections was that the rendering physician number was invalid or missing. Maybe you billed it under a physician no longer there. Maybe there was a transposition when the claim was entered. So these are top rejections by reason. Remember I said that we can mine the data, or we can look at the data different ways. We can look by state, by county, by reason. Here are more top rejections by reason. The clinic number is missing or wasn't entered accurately. 132 rejections, 99 rejections. Remember, these are only specialty 83 claims. The injection was denied because the name and the dosage was not furnished. 84 rejections occurred because the CLIA number was invalid or missing. 82 were denied because the claim should have been sent to United Mine Workers of America for processing. And 56 rejections occurred for invalid or missing modifier. These are pretty straightforward when you read these reasons for rejections. So for rejected claims or those that are unprocessable, as I mentioned earlier, you need to fix it and resubmit it. So these are rejections by reason. Here are the top rejections for specialty 83 by HCPCS codes. The number one CPT code that was rejected by WPS was 99214, which is an evaluation and management service, followed by lab service there 301 or 301, the 85025, 36415, that venipuncture code, 240 rejections, J7030, 217, and you can see on and so forth. The top rejections by HCPCS codes. I find it very, very fascinating to look at this data. I can tell you that when I pull this data, it's a matter of filling out filters, if you will, and hitting a button, and within seconds, this information comes back. There's a lot of information tied to these reports. Before moving on, though, I do want to tell you it will give you information such as the dollar amounts that were rejected, the dollar amounts denied, and so on and so forth. How many claims, how many PTANs, how many beneficiaries. So just a very interesting way to view this data. And like I said, it comes back just in a matter of seconds. All right, let's move now. I talked about rejections. I want to talk about denials, those top denials by reason. Look at the first couple. Duplicate claims, 3,185 duplicate claims because the charge was already paid on another claim. Those question marks and numbers and X's, that stands for a date. Duplicate charge paid on such and such a date on claim such and such. So the question mark and the second line there, it's a stand-in for the ICN of a claim. The first one is for a date, the second one is the ICN. So the claim was already paid on this claim or on another claim. The second one isn't quite that descriptive. It just simply says this is a duplicate charge, 1,754 claims. So, I mean, imagine this is just specialty 83. If we take a look at all of the other specialties in Medicare, think of the number of duplicate claims that we are denying every day. That costs the Medicare Trust Fund money, you know, to deny those services, to process those claims. It also costs the providers money for preparing and submitting those claims and then looking at them, looking at these denials when they come back to you. So, you know, we try to include education to alert providers to the fact that this remains one of the top reasons for denial. It costs everybody money if you're using a billing system or a billing service that automatically submits a claim. If you've not gotten information back from Medicare within a month, we recommend that you stop doing that because this is what happens. All of these duplicates are being submitted and rejected or denied. I caught myself there. They're not rejected, they're denied. All right. Another top denial by reason, the claim must be sent to the employer group health plan first. So this is one of those Medicare secondary payer situations. For this, what you can do is, you know, check to see, check with the beneficiary if anything's changed in their coverage. I realize, and I've heard it from providers when I've talked to them before, that you don't always know that there's been a change. I recommend that you ask them for that card each and every time they come in. Do you have more than one card? Sometimes they do. Sometimes they're not all current. But that's just more questions and such on the front end might help avoid this type of denial. Payment included in another service received on the same day. Well, this means bundling. Um, Check the National Correct Coding Initiative edits. Check the procedure to procedure code edits to see if the payment for the column B or column 2 code is included in the first column or column A column. If so, check to see if there's a modifier indicator in those procedure to procedure edit tables that will avoid this type of denial. But just because it says you can add a denial, or excuse me, a modifier to prevent this denial doesn't mean do it. It means check your medical record documentation to see if the documentation justifies use of a modifier to unbundle the service. Here is another top denial by reason the time limit for filing your claim has expired. 738 denied claims in that 3.5 month period. You have 1 year from the date of service to file your claim. We understand that there are situations at times where the information that the beneficiary presents at the time of service isn't current, or that there's a change made later. There is a mechanism for you to ask Medicare to waive the timely filing. That there's information out on our website that tells you how to do that, because this is going to be a hard edit. It's going to deny if that claim, that time limit has expired, but then you'll need to request an appeal, or you'll need to request that waiver for timely filing. And there's, like I said, there's resources available on our website that tell you how to do that. Basically, in a nutshell, you need to contact the manager of our claims department and request that, and present evidence why your claim was submitted untimely and why Medicare should make payment for that. More top denials by reason a skilled nursing facility episode of care notice has been filed for this patient. So patients in a skilled nursing facility, some services are excluded from payment then under Medicare Part B. So there were 535 denials. For this type of denial, I would suggest taking a look at the education on our website that we have for skilled nursing facility, or SNF as we like to call it, consolidated billing. There's a lot of great resources available. Remember that we have our YouTube channel. There's a good number of videos out there that explain consolidated billing. So that's what you'd want to look for to avoid the denials here. Denied services or service or units of services are exceeded, 449 denials, and this would be due to a medically unlikely edit, an MUE. Now, not all MUEs are published. There's tables out on CMS website that tell you the number of units of service you can bill, same beneficiary, same data service, same provider. If you exceed that number of units that's published, your claim will be denied. It's a hard-coded edit. So if the MUE is 5 and you bill 8, we're going to allow 5. That's it. However, you can request an appeal and present evidence to Medicare why those additional 3 were medically necessary. I am going to be hosting an MUE webinar in January. So if you want more information on avoiding that type of denial or on medically unlikely edits, sign up for that or register for that webinar coming up in January. Let's look at the next top denial reason. Medicare will not pay for this service for this condition. 375 denials. Typically, that is going to mean diagnosis. So diagnosis would be one of those situations would meet medical necessity. So when you have this type of denial, what you're going to want to do is consider presenting your patient with that advanced beneficiary notice of non-coverage. Um, you will need to check to see if there's a national coverage determination or a local coverage determination that might show you which conditions Medicare will pay for a particular item or service. Next up, referring provider is not eligible to refer this service, 330. Some provider types can't refer items or services for Medicare. So that's something to look into. Like for most of these things, you're going to be able to find some great resources on our website that talks about eligible referring providers and so on and so forth. And for all of these reasons. The next one is also an MSP or Medicare secondary payer related denial. Medicare is secondary, send the claim to the primary payer first. And again, this is one of those situations where you're going to want to ask your patients each time they come in, did something change? Do you have a new card? Those types of questions, trying to avoid these particular denials. So then folks, here are the top denials by HCPCS codes. 99214, 1622, and I think it's interesting that the top rejections by HCPCS codes, the first two codes were the same. I just happened to notice that when I was preparing the PowerPoint. 85025, lab service 1005, denied by WPS. 36415, that venipuncture, I think that was also on the list of rejections, and so on and so forth. You can see many of these were the evaluation management services, course injections, and administration codes as well. So these are the top denials by a HCPCS code. Question from Elena that I'm seeing out there now. It's kind of like right in my eyes because of that MUE, and I just talked about MUE, so I'm going to stop now and talk about that. For the MUE, should we be splitting the charges? The MUEs 5 and 8 are billed. You do not have to split those charges in this particular case for MUEs. For other types of denials, I can't really answer unless I know specifically what types of denials. So no, Medicare doesn't ask you to split those out. We're going to pay up to the number of MUEs. But I'll tell you what, I am going to check to see if that has changed. I've not been asked this question for a while. So Leanne, I'm going to ask you to send me a message on the side so that I remember to come back to this question. Actually, we'll just print all of the chat messages, so we'll have it. But I'm going to follow up on that and make sure that there hasn't been any new instructions that I'm not aware of, because it has been a while since I have been asked that question. So let me follow up and verify, Elena. That's a great question. Thank you so much. All right. I was mentioning this to you a little bit earlier, all the fascinating types of data that we can look at. We can drill down by state. If we drill down, for example, I did some presentations in Michigan this past fall for both mental health groups and oncology. And I could actually drill down for Michigan only, and then it tells you by county the reasons, or by county the codes. So state by reason, county by reason, state by code, county by code. And remember that these reports actually provide even more data than what I'm showing today. You know, the number of PTANs, what's the beneficiary count, how many different docs bill this, and what is the dollar amount lost due to these denials. So it's just incredible how quickly you can view all of this information in the dashboard. I want to talk a little bit about trending before I open it up to questions here. We can look at trending for unprocessables and denials, and one of the things that CMS asks us to do when we report back to them on each one of our events is, you know, did you provide education based on data? Yes. How do you know it's effective? Well, this is going to help us know if it's effective. Trending. We can trend for unprocessables, we can trend for denials. And in those reports, it's going to give the code description, claim count for the current 3 months. It's going to show the claim count for the prior 3 months, the difference, the claims percentage, and the difference in the claims charge, the overall claim count 3 months prior, overall claim count for the current 3 months. Now that's a lot of words on one slide, so I thought if I actually showed you trending, it might be easier for you to follow all of these words. I like to see a visual, so I'm sharing with you a visual. So here is trending for a specific situation, a denial example. The reason code is a 147. Here's the code description. I mentioned this to you earlier. Duplicate charge paid on this day on this claim. So this trending that we can look at on this dashboard shows me for that code description, that code, the current 3 months is 3,185 denials. It also shows me that the 3 months prior was 2,298. So the difference in claims is 877. The claim percentage change is 39%. And then the last column, when I look at this dashboard, is an arrow that points up or points down. That trending dashboard that we can look at. We can look quickly and we'll look at all of those red arrows that go up and all those green arrows that go down. That helps us really quickly and visually see trending, okay? And this is just the tip of the iceberg. This is a dashboard that our data folks built for our PO team, and PO stands for Provider Outreach and Education. So I'll be offering up a series of these webinars on, talking about the various specialties denials. It's been something that some of our providers have been asking for quite some time. Can you provide some education on anesthesia? Can you provide it on, foot care? And I think sometimes that the best way to educate is to show these are the claims that are being rejected and denied, and here's where you can go for help. Here's how you can find the information that tells how it must be submitted or in what format, and so on and so forth. And I did mention to you, and I'm sorry that I didn't come across the slide that showed it. I mentioned to you the claim form instruction are in the internet only manual. Item 1, Item 5, Item 24J, what do you put on the paper claim form? And then I mentioned to you that we have a crosswalk that says, if it goes here on the paper claim form, this is where it goes electronically. There's a long name to it. I know the word crosswalk is in it. I am going to follow up after this webinar today. It might not be today, it might be tomorrow, and provide you with those two resources so that if you submit electronically, you have the crosswalk. If you submit on paper, you know where to go in the internet only manual that says what has to go where on the claim. And the great thing about that crosswalk document is it will tell you whether it's conditional or situational or whether it's a required element. Where do you need to put it on the claim form? Is it required or is it situational? It's a really, really helpful tool. So I will get that to you. I thought it was in here. It's not, I don't believe. All right. That brings us to questions, and my friend and colleague Leanne is standing by. I know I can see the chat, but she's been monitoring it so she can see what's come in earlier. Leanne, are there any questions?
Mary, we do not have any questions at this time.
Before I leave, I want to share with you that one of your greatest compliments would be, or our greatest compliments rather, would be for you to recommend our education to others. I know some of you work in a small office, but others are part of a large team. Some of you belong to various professional education or professional associations rather, and societies. Please consider recommending our education to others when you have an opportunity. Doing so helps provide needed education to the greater provider community. On behalf of myself and Leanne and the entire Provider Outreach and Education team, thank you for your participation today. The dog that was just removed from the room also thanks you. We look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect. Thank you, everyone.